Welcome, everyone. This is Dr. Chris Link at the Integrative Medicine Clinic, and this discussion is about osteoporosis, an integrative approach. Osteoporosis is a very important medical condition. 1 in 3 women and 1 in 5 men will suffer an osteoporotic fracture sometime during their lifetime. So it's a very prevalent condition. And it's a condition that we can significantly reduce with the right sort of interventions, particularly early on. And it's where the integrative approach, where we use nutrition and exercise and supplements as indicated, along with medication when needed if the condition is serious enough, that they combine so well to provide the very best outcome for patients. Osteoporosis is a condition that's very important to me for both personal reasons, family history, and also the fact that many of my patients have significant bone mineral density issues and health-related concerns. It's an area that I spent a great deal of time learning about and teaching about and providing care for. Tonight, we're going to look at all aspects of osteoporosis, from the cause, the diagnosis, the treatments, including both the complementary and integrative approaches, that is, nutrition and exercise and lifestyle and supplements, and also medications, and how medications, if needed, can be used safely to provide the very best outcome for patients. Again, welcome to this talk from the Integrative Medicine Clinic. I hope you enjoy it and find ways to improve your health.
We're going to talk about the following things tonight. What is osteoporosis? Just how prevalent is it? When should we screen for it? How can we prevent and treat osteoporosis? Why are medications important? Can medications be used safely? And I know that's a big question that many of you probably have. I know I have. And in your questions as we go forward, we'll make some time at the end to answer questions as well. But again, you can ask some as we go forward. So I'm excited you're all here, and we will continue to move forward here. So osteoporosis is clearly a major public health concern. And again, when I was in medical school, I did not understand that. And in the 1980s, there was really not very much we could do about osteoporosis. We could certainly diagnose this. We saw it with folks that would end up being debilitated, like this poor lady on the left, or people that would end up with hip fractures, but we didn't have great treatment. 1 in 3 women over the age 50 years and 1 in 5 men will experience not only osteoporosis, but a fracture from osteoporosis. And you can see the picture of that. That's the ball in the neck of the femur, the leg bone there. And on the left is a healthy bone where it's pretty dense. There's a thick cortex that surrounds the bone, and the trabecular network in the center of the bone is really it's strong. And the reason we have that trabecular network is because if the bones were solid all the way through, we'd have to carry a lot more weight. So we have this lattice structure that holds the bone and gives it great strength without being so heavy. But you can see on the right, as a person may develop osteoporosis, the cortex gets thinner. That is the area around the bone. And then we start to lose the matrix or the trabecula inside the bone, and the bone becomes much more likely to fracture. When a person has osteoporosis, particularly when they develop spine fractures, they start to lose their ability to move appropriately. You can see this lady off to the left where she's stooped forward. It changes her ability to breathe. It changes her rib cage. It actually, the whole rib cage sinks towards the pelvis. So it lessens the room in the abdominal or gastric region. So digestion is impaired. It also changes their mobility. So a person's more likely to fall. You can see she's not able to fully walk upright. This changes posture. It changes the ability to have a stable fluid gait, and falls increase. People that have this, they have often chronic pain and disability, and sometimes premature death because of it. So it's a really important condition. Now, this is a scale, and it's to indicate that balance is really important. And integrative medicine, just in general, tries to balance the use of the basics that we know that keep people healthy: great nutrition and exercise, sufficient sleep, stress management, supplements when needed, along with medications. In integrative medicine, we tend to emphasize, so we think on the left, where we give more weight to trying to use prevention and all of these strategies that include lifestyle, nutrition, exercise, and these sorts of things. We certainly use medications, we integrate that. We want to use the medications necessary when needed, when they really make a difference. And it's really about finding the right balance for the patient, because not everybody can exercise intensely, or not everybody is willing to eat a terrific, diet, but they can do better. So it's finding the right balance, using the medications necessary to keep them healthy. And when it comes to osteoporosis, it's the same sort of thing. We need to know the risk the person has, and then use all of the things we can use, the nutrition and exercise and supplements, but often medications are needed to get a patient to the place where they have healthy, solid bones that are going to last them a lifetime and decrease the risk of falls and fractures and disability. So there's a synergy between exercise and nutrition and medication. And these three things, that is, I think exercise, nutrition, and medications are the three most important things in osteoporosis management. Now, hormones are part of that. And so certainly younger women that have high levels of estrogen, they have the likelihood of osteoporosis is much, much less. We'll talk more about that. But clearly exercise and nutrition is very important. And down below here, and these are other things we'll talk about today, are these supplements. And these can make a difference, but they don't have the same sort of weight that exercise does, and nutrition, particularly a high protein, colorful diet that makes such an important benefit, adding olive oil. We'll talk about all of these things. I won't mention them all specifically now, but from vitamin D all the way down to strontium, if they're helpful. And I believe they are helpful, but often not as much as the ones listed above. So the risk factors and the underlying causes of osteoporosis are many. Somebody could have vitamin D deficiency. They could have malnutrition. They're not getting enough nutrition, or they're not getting the right nutrition. I see more osteoporosis in adults that eat a vegetarian vegan diet that I do in a person that's an omnivore that uses some animal products in their diet. So that's important. It doesn't mean that you couldn't have a healthy diet as a vegan or a vegetarian, but there's much more of a challenge to get sufficient protein. Things like smoking and excess alcohol play a role. Being underweight, or not enough physical activity and not enough lean muscle mass. Certain medications, the ones listed on the right, the PPIs, prednisone, which is a steroid, birth control pills, SSRIs, the antidepressants, and aromatase inhibitors that are involved in cancer therapy for women with breast cancer. All of those decrease bone density, or potentially. So those are some of the underlying causes of osteoporosis. And some of you may know about the major cells involved in building bone. And this is a balance too, interestingly. There's a key cell called the osteoblast, and that actually helps to make bone. It makes bone stronger, it builds bone. And then the osteoclast break down bone. There's always bones are dynamic. You're always building and breaking down bones. And when you're a teenager or a young adult and you're still growing and adding some muscle mass, for example, you're going to have the balance where you have more bone formation. When a person is postmenopause, or if they are becoming more sedentary, or if they're eating a low protein diet or other things, they may have an increased and inflammation, for example, increased osteoclast activity. Now, the major drugs that classes are anti-resorptive drugs and anabolic drugs. So on the left here, the anabolic drugs, Forteo, Tymlos, and Evenity, they turn up osteoblasts, so they build stronger bones. They're terrific medications. And along with that, exercise and nutrition really turns on these osteoblasts as well. The anti-resorptive drugs you've probably heard of, things like Fosamax and Reclast and Prolia, they turn down the osteoclast activity. So you can work on either side of this balance, this equation. And if you turn down osteoclast activity because you're already going to have osteoblast activity at some level, you'll still build bone, or you'll or if you turn up the osteoblast, the bone building cells, you'll win that balance as well. Inflammation, loss of estrogen and testosterone also impacts the osteoclast. I'm going to talk to you about a case, and so some of these things, we're going to review this case of this man with osteoporosis and how exercise, nutrition, medications, and some of these things will not have been fully explained to you. We're going to talk about it'll mention about DEXA scans and T-scores and so forth. We'll get into the specifics of that, but I just want to present this case because I think it's important. So in 2010, this man was 49 years old, and he had a lumbar spine and a femoral neck. That's the most important part of the hip at negative 2.7 and negative 2.1. So that clearly had osteoporosis. Surprisingly so, it occurred. He found this out when he had back surgery. And the surgeon said his bones didn't feel right. He went to St. Louis, saw a specialist, and was started on teriparatide, which is also known as Forteo, and that's a bone building medication. He was on it for 2 years. Amazing improvement. The lumbar spine was clearly out of the osteoporosis range and remarkably better. Soon thereafter, he was diagnosed with celiac. Celiac is a condition that causes inflammation and kind of a denuding or a thinning of the upper gastrointestinal lining, so a person doesn't absorb their nutrients like calcium and protein as well. And that was one of the reasons probably this person had osteoporosis. And typically after a bone building medication, we give an anti-resorptive medication. I'll talk about that more here in a few minutes as well. But once you build the bones, you want to use an anti-resorptive to hold on to it. It's kind of like a dental sealer. It holds and protects the bones from losing too much density and strength thereafter. But the person decided not to do that. Instead, he used calcium, vitamin D, vitamin K2, and exercise. And over the next 7 years, his bone density continued to decrease further and further and further, and not quite to the extent it was in 2010, but at age 58, he was nearing osteoporosis again. So at that time, this individual really engaged in a high protein diet, collagen daily, exercise nearly every day, something called blood flow restriction therapy that augments exercise. I'll talk about that, a jumping program, and this trekking. So if you look over on the right, you can see the trekking picture there, indicating the use of the muscles that are different there. Just below that, you'll see something about these bands that are above the upper legs and then also in the upper arms that augment muscle building. And again, we'll talk more about that in a minute, and then a jumping program. And within a year, in March 2020, with no further medication, there was a remarkable improvement in bone density. Lumbar spine was down to negative 1.7. It was even better than it was after the medication. And then 3 years later, continuing this program, bones are nearly normal and very strong at negative 1.5. So the reason this person probably had osteoporosis with the celiac, but because he was an ER doctor and this patient is me, he had lots of stress in his life and had a back condition. I had surgery in 2010, so I wasn't lifting and loading my spine the way I might have otherwise. But with all of these things, this integrative approach that used medications and then also the nutrition and exercise and the fact that I'm no longer an ER doctor, my bones are a lot healthier. And this is one of the ways and one of the reasons I became so passionate and well-informed in the area of osteoporosis management, excuse me. Now, another way, I'm going to take a drink here. Another way that I've become informed is I've been involved in this project called the National Bone Health Teleecho Program. This program was started in 2015, and I became a member of it in 2017. It's a weekly 90-minute seminar on bone health. And what they've decided is that through the University of New Mexico is that there's not enough bone health specialists at the universities to go around to take care of everyone around that has significant bone health issues, and they wanted to improve the way they got this information out. So they recruited 10 to 12 researcher bone health specialists at different universities, like the University of Alabama, University of Tennessee, Colorado, Harvard, and they make themselves available each week for 90 minutes for people around the country to learn from them. We do case presentations. There's a short 30-minute lecture, and I've done this 40 or 50 times a year for the last 8 years or so. It's been terrific. And there's a big square in the middle Missouri, and that's my involvement in the program. So I've been involved significantly in this ECHO program, where there's a force multiplying, where instead of bringing the patient to the specialist, you bring the specialist knowledge to the patients of the country through the primary care providers like myself. And this was started actually about a decade before in Africa, because there they clearly don't have enough specialists. And they use this again as a force multiplying way to provide great information, great care to patients throughout the continent, even though they don't have enough specialists. This has been so effective that it's now used in endocrine health, infectious diseases, substance abuse, COVID-19, bone health, like we talked about, dermatology, and much more. And it's been so effective that other disciplines like education and other areas are picking it up as a great tool to use to improve the quality of whatever they're trying to teach and provide in the community. Okay, so now we're going to look at osteoporosis guidelines, and this is based on the American Association of Clinical Endocrinologists. Their guidelines are the most recent in 2020. And who should be screened? Well, they say every woman 65 years and older. By the way, they recommend 70 for men, and that's reasonable. Postmenopausal women that have a history of a fracture without major trauma. So if a person has a fracture from a simple fall, for example, that person should be screened as well. And then all of these other reasons, if you have low body weight, or if you, for some reason, needed to be on extended doses of glucocorticoids like prednisone or cortisol, if your mother or father had an osteoporotic fracture, if you had early menopause, my mother had osteoporosis and she had menopause in her late 30s, tobacco use, alcohol use, these sorts of things. So physicians have great latitude to screen early with the DEXA scan. We'll talk about that in a minute. So though the guidelines say, these ACE guidelines say 2020, it is Dr. Link's opinion, and I'll show you why, that women are best screened at the time of menopause, that to see what their bone status is at that time so that we can use some of the preventive measures before osteoporosis may set in. So some of you have probably had a DEXA scan. This is a DEXA machine. The first thing I want to show you or point out to you is this young woman that's sitting next to the patient doesn't have a lead apron on. She's not protecting herself in any way. The reason is that the radiation from a DEXA scan is so low and so safe. Now, at the top here, the question was, what percentage of women actually get a scan by the age of 65? And it's less than 50%. What we know is that DEXA is inexpensive, accurate, reproducible, highly correlated with fracture risk, and it's safe. I'll give you an example. We measure the amount of radiation in a unit called millisievert, and mammogram has some radiation, not a high amount, but it has 0.1 millisieverts. An X-ray of the chest is 0.4. A DEXA scan is 40 times less than a chest X-ray. It's a very safe, very low radiation. A person can clearly have it every year for the rest of their life without significant concern for radiation exposure. The key sites we look at is the lumbar spine, the lower back, the femoral neck, which is a thin part of the neck of the femur. Sometimes we look at the total hip, and we also look at the distal third radius that's near the wrist, the radius bone, the end of the radius bone here in the wrist. And this can be done every 1 to 2 years when a person's in treatment. Medicare covers DEXA scan every 24 months, and notice here, and more frequently if medically necessary. If the provider orders it, that means it's medically necessary. And conditions like hyperparathyroidism, chronic kidney disease, or active treatment for osteoporosis. And if for some reason an insurance company doesn't want to pay for it for you, there are institutions, medical facilities in mid-Missouri that you can pay for a DEXA and at less than $150. So this slide really indicates why I think we should do it earlier. So the open dots are that of men, and osteoporosis tends to happen in men in their 7th or 8th decades of life. But in women, the incidence of osteoporosis starts going up right at age 50, and that's right at menopause. And some women, not so much, but many women will lose 5 to 10% of their bone density in the first 4 years of menopause. And so if that woman has relatively low bone density or lower bone density at the beginning of menopause, we'd really want to get going with the right protein, with the right exercise, maybe replacing our hormones to prevent that. And it's very preventable. When you get a DEXA scan, you're given the T-score report, the T-score. And a woman at the age of 28 at her peak bone density will have a T-score of 0. When she's 50, an average woman will have a T-score of the spine of -1. And when she is 75, the average woman will have a T-score of -2.5 at 75 years of age. A T-score of 0 to 1 is considered normal. You can see that on the right. A T-score of -1 to -2.5 is osteopenia, or low bone density. And lower than -2.5 is osteoporosis. I'll also talk about the FRAX score here in just a minute. Now, we diagnose osteoporosis if the T-score is less than 2.5. We also can make the diagnosis of osteoporosis if the T-score is in the range of -1 to -2.5 if they have a low trauma fracture. That is a hip fracture or a pelvis fracture or shoulder fracture or spine fracture without some major trauma like a motor vehicle accidents or a fall from a height. If you fall from ground level and fracture, that means you very likely have osteoporosis. And I'll tell you, one of the things that's concerning is that people will go to the hospital and they will be diagnosed with a hip fracture, they'll have it treated, and they won't necessarily be referred for treatment of osteoporosis. These days, though we're getting better at it, we don't necessarily do that. And I actually had a patient today that had a hip fracture a year ago, was seeing me now, and it had never been sent to someone for osteoporosis management. Now, if you're in the yellow, the osteopenic range, nutrition, exercise, hormone therapy, supplements are likely to make a difference, and you just follow to make sure. But when you get into the red range, less than -2.5, it's very likely you're going to need nutrition, exercise, possibly hormone therapy and supplements, but medications too, because the risk of fracture changes a person's life, as we noted earlier on the slide with the woman with the stoop posture and the abnormal gait, etc. Now, this is the FRAX tool, and this is available free online. If you know your bone density of your hip, and you can get that from the DEXA scan, and then you put in your risk factors, things like if you have a history of falls, if you've had a previous fracture, if you have diabetes, which lowers your bone strength, if you have use of glucocorticoids or prednisone, well, that increases your risk. And this is all put into an equation called the FRAX tool, and it will give you a prediction of what your risk of fracture is over the next 10 years. We use this often. So this slide, forgive me, I'm going to take another drink. This slide looks at the labs we need to look at. We want to look at a CBC that tells us about the red and white blood cells, a CMP that tells us about calcium, electrolytes, other electrolytes, and kidney function. We certainly want to know a vitamin D level, and because phosphate's an important mineral for bone. We want to check that. And we want to check a 24-hour urine calcium because some people have this condition called hypercalciuria, where they lose too much calcium in their urine, 5 to 10% of the population. So if you're constantly losing calcium in your urine, your body naturally, because it wants to balance your calcium in your blood, is going to be drawing it from your bones in order to balance that. We want to look at thyroid function. That's the TSH. We want to look at labs that tell us if a person has celiac, and I certainly diagnose that with osteoporosis. Things like cortisol, and there's other things, tryptase. The other real important one, and the ones I think they're all important, but particularly important are to look for parathyroid hormone abnormalities. These are 4 tiny glands that live just behind your thyroid gland. If they are overactive, they create a hormone called PTH, and that seeps or draws calcium abnormally from your bone. We're going to move into exercise, and Dr. Laura Gianna Gregario is a professor of physical therapy, and she's an osteoporosis specialist at Waterloo University in Canada. And she said exercise should be used as the first line therapy for bone health, and I can't agree with her more. She goes on to say that walking is a great exercise, but it's insufficient to improve bone density, that you really want to do some sort of weightlifting, progressive resistance training. There was an interesting study called the Lift More study, published in 2018, where they had adult women in their 8th and 9th decades of life, that is between 70 and 90 years old, do heavier weightlifting, and they had increased bone density without any significant side effects. You also want to do balance challenging exercises. Tai Chi, you see this on the right. Tai Chi is a fabulous exercise for many, many reasons. Clearly improves your balance. It helps with cognition. It improves symptoms of Parkinson's disease. It does all sorts of wonderful things. But people who can stand on one foot like that have a much better balance and are much less likely to fall. Now, some of you have probably heard about OsteoStrong, and Dr. Laura Gian Gregario has a 5-minute video that's on YouTube, and you could put her name in that if you can remember how to spell it, Gian Gregario, again from Waterloo University. And she looked at 3 things that you ought to know about OsteoStrong. The first thing she said is there's no randomized controlled trials reporting the effects on bone mineral density. Though there's lots of advertisement, there's very little data. There's no randomized controlled trials that prove it is safe. I know of people that have had a fracture from OsteoStrong. There are other better options. So I don't recommend this. It's certainly an exercise, but it's if something that's going to be marketed to the country widely as an effective treatment, they need to put their money behind proving that it works and that it's safe. Now, I mentioned a little bit about blood flow restriction therapy, and some of you may know about this. There's a wonderful video by Dr. Jim Stray Gunderson on YouTube, and you could just put in Dr. Gunderson and blood flow restriction and bring that up. Dr. Gunderson was the team physician for the U.S. ski team, and I learned about it, blood flow restriction, from him, and I've been using it myself for many, many years now, about 8 years ago. And it was developed in Japan. You can see on the slides on the right over there, it looks like a blood pressure cuff that's on the upper arm or the upper leg. It's not as wide as a blood pressure cuff, and it doesn't get as tight as a blood pressure cuff either. It gets firm around the arm, still allows you to exercise, and it restricts the blood flow modestly, but not completely, to the arm or to the legs. It is now used by professional sports team, Division I schools. It's used at physical therapy departments, both here in Jefferson City and in Columbia. The mechanism, again, is it restricts venous blood flow, and it allows you to get a profound muscular workout with much lighter loads. So, we talked about in that Lift More study that those ladies in their 80s and 70s and 80s had to lift heavy loads to build bone. Here, you can lift lighter loads and have a significant benefit. It stimulates a very robust anabolic, that means a building response in the body through things like growth hormone and mTOR and IGF-1, things that we won't go into detailed explaining, but these are important messengers in the body to tell the body to respond, to adapt, to build stronger muscles and bones. We've been teaching through our physical therapist that works with us here at the office, Carol Sawyer, this for many years, and we've got several patients that have used it. Muscle damage is minimal and strength and fitness adapts rapidly. So it's something that's quite interesting. We're going to move into nutrition. And the two things to remember is protein in plants. Protein provides the infrastructure for the bone. The bone is not just calcium. Calcium is certainly an important part of the mineral density of the bone, but the underlying structural, the 2x4s, the lattice structure is also very important, and that is protein and particularly collagen. And plants are really important because they provide the minerals that are important, the trace minerals and magnesium, and they also change the pH in the body. At the surface of the bone and in the urine that allows us to put calcium in our bones better. Now, grains and starches are not that helpful. That's not that you couldn't eat those, but the real benefit is in the plants and the protein. The RDA, the recommended dietary allowance for protein, is too low. In fact, it's kind of a misnomer. What that is, the RDA really, and it's 0.8. I think the RDA is 0.8 grams per kilogram, so it's much less than what I mentioned here at 0.8 grams per pound. Is enough to keep someone that is fit from not having malnutrition from protein, but it's not optimal for their health, for their immune system, for their muscle structure and their bone structure. And what we find is that if you really want to build bone, it's about 0.8 grams per pound. And for a 150-pound person, that would be 120 grams of protein daily. Older adults, you get into your 60s, it becomes more of an issue. Younger adults and teenagers are able to use smaller amounts of protein to effectively build muscle. Older adults have developed, as we get older, anabolic resistance, so more is necessary. So optimally, you want 30 to 40 grams with 3 meals, and I'm going to go through why that is. So you wouldn't want to eat all the protein at any one meal because you can only really use about 30 to 40 grams per meal. And then you need about a 3 or 4 hour window between meals for your muscles so you get the initial meal, you eat the 30 or 40 grams of protein. We'll discuss what that is in a minute. And that tells the body that it's getting enough protein, that it has some excess, that it can build muscle. If you have less, 10 or 20 grams, you don't get the stimulus to build muscle. And then you need a window where where you're unfed for 3 to 4 hours, about 4 hours, and then you can have another meal, and then the body will respond again. So you have 3 opportunities during the day to build muscle and bone with your meals and protein. You want to eat your meal, and you want to start in the morning with 30 or 40 grams. Many adults have a small protein breakfast, maybe 10 or 20 grams. They'll have an egg or 2 possibly, and then a lunch that may have a little bit more, and a dinner that might have a lot more. That's an inefficient way to use. You're not going to get the most anabolic, that is, building response for muscle and bone. These are an example of about 30 grams of protein. Something like 3.5 ounces of chicken, 3 to 4 ounces of salmon. And note that an egg has about 7 grams of protein in it. So if you're going to get 30 grams, you're going to have 4 to 5 grams. Or quarter pounder of beef will give you about 30 grams of protein. You can see that nuts and dairy and things like this, beans, all of these can help you. Tuna, you need about 4 ounces of tuna as well. So that gives you an idea of the foods that will provide this for you. You can also use to try to augment what you're doing during the day. Though real food is best, certainly have a better response. You can use a protein shake or something like that as well. Vitamin D, it's pretty simple. We want to treat to target, so you really need to measure your level. For most people, they can get to a target of 40 to 50 nanograms with 1,000 to 2,000, but I clearly have multiple patients in my clinic that need 5,000 daily or most days. And the other thing about vitamin D that I think is really important, this is a British Medical Journal study in 2017, is that in their study, they showed that there's a new major indication for vitamin D. It's called prevention of acute respiratory tract infection. So we know that vitamin D is really important for bone health, but it's also really important for our immune system, both to help our immune system respond appropriately to infection like viral infections, but also for us not to over-respond and have an abnormal immune response like autoimmune disease. So vitamin D is very important. And this study here showed that when we look at all-cause mortality and we line up vitamin D levels in the 50 to 60 range gives us the lowest all-cause mortality. That means dying from any reason. So vitamin D is important. It reduces the risk of cancer as well in many studies. Calcium. Many adults are taking too much. Calcium is important. And I'm just going to use this analogy. Some of you may have heard me say this before, but and some of you may be old enough as I that went to a grade school where you actually used chalk on the chalkboard, the blackboard. And recall how brittle that was. It was very easy to break. You know, calcium that was in that chalk carbonate there is not very strong. But if you instead if you instead put some structural components in it, like the protein matrix that I talked about, that trabecular matrix, it makes it much stronger. That's why the protein is such a key. A sweet spot is about 1,200 milligrams for adults, women over 50. And it's optimal to get it from your food if you can. We'll talk about great sources of that here in a minute. Food is optimal. Average American that has dairy in their diet will get about 600 milligrams in their diet. And if no dairy, they may only be getting about 300 milligrams. If you take too much calcium or have too high a vitamin D, you can be at risk for kidney stones. But calcium in the normal ranges does not increase our risk of coronary or other vascular calcification. I was asked that question today by a patient, I believe. But excess calcium is a cause of constipation for sure in many people. I see that not infrequently. So what I recommend, calcium carbonate is just fine, a 500 milligram tablet. So if you're having a diet where you're getting 600 milligrams and you take one calcium carbonate or a half of one twice daily, that would be great. That's not my favorite calcium. My favorite calcium is calcium citrate for a variety of reasons. There is less GI side effects, less kidney stones. There's lots of benefit to it. And those capsules are typically 250 milligrams, and you take 2 of those daily. And that will clearly get you in a terrific range, all you need for bone health. People do not need to be taking 1,200 milligrams of calcium supplementation. You need about 1,200 with the diet and your supplements together. Now, people who have had gastric bypass surgery and things like that may need a lot more. And the last thing that I underline there is that these special calciums that you'll find at the health food stores, they have no benefit. Algae calcium or calcium from this or that. Calcium citrate is very effective. It's inexpensive and it's well studied and well tolerated. So a cup of milk, so that's 8 ounces of milk, will give you about 276 milligrams of calcium. But look, you can get, with a cup of almonds, you can get almost 400 milligrams of calcium. With 1 cup serving of bok choy, you can get 158. Or a cup of broccoli, you can get 74. Some herring, you can get 100. So there's lots of places to get dietary calcium from food sources. So a few things about magnesium. Magnesium is another important mineral. It's not as important as calcium for the bones, but it's important because it's clearly in our bones. And if you don't have enough magnesium, and many Americans are deficient in magnesium, it leads to a vitamin D resistance, and it can lead to low calcium or hypocalcemia. It can impair parathyroid function as well. Great sources of magnesium are green leafy vegetables, nuts, seeds, grains, beans, and dairy. And many people ask me this: magnesium, does it need to be taken with calcium? The answer is no. You just need to get enough magnesium in your diet, and you need to get enough calcium in your diet, but it's not necessary to take them simultaneously. They don't have to be, they're not yin and yang. They don't need to be taken together. Now, strontium, I've underlined, generally not recommended. And any of you that have osteoporosis and maybe taking supplements or have low bone density or concerned about your bones, you may be taking some bone supplements. Take a look at them. Make sure that it doesn't have strontium in it. Many of the over-the-counter supplements for bone health do have strontium. And the reasons why is that strontium falsely elevates bone mineral density, and it distorts the DEXA testing for the next 7 to 10 years if you take it, and it doesn't necessarily improve bone strength. So the density can get higher, but the strength may not be better. The reason that it's higher is that you might remember in chemistry, there's a periodic table and there's a line of these divalent cations like calcium and magnesium and strontium. Strontium is heavier on this periodic table. That's why it's more dense, but it doesn't mean it makes bones stronger. The other issue is that the strontium product that they used in Europe, strontium ranelate, was associated with increased risk of venous thrombosis and embolism, a serious skin condition called DRESS syndrome, and increased heart attacks. The European Medicines Agency, the same as our FDA or similar to that, in January 2014, no longer recommended the use of strontium. And strontium citrate and strontium chloride, which are available in the US, have not been tested for efficacy, and that is, do they work and are they safe? So I recommend that you stay away from these. There's better options. The question was just asked about how much magnesium a person might take. If you're eating a really rich diet with plenty of colorful greens, you probably don't need very much. And in fact, you probably don't need any supplementation of it if you have a really diverse diet. If you know, some days or many days your diet is not as helpful because of a variety of reasons. You're just really busy in your life. Then taking magnesium, something in the range of 200 to 400 milligrams daily, something like you can take magnesium citrate, you could take magnesium glycinate or other chelated magnesium. So 200 to 400 milligrams would be reasonable. Calcium causes constipation. Magnesium tends to loosen the stools, so it works in an opposite direction. So that's something you'd want to watch out for. So if a person has constipation, not a bad idea to take some magnesium just for that because it's really safe. But if you're taking magnesium and your stools are if they're just too loose for it to be comfortable for you, then you want to back off on that. Now, collagen is an incomplete protein. It does have amino acids in it, but when you're looking to get your 100 or 120 grams of protein a day, don't count your collagen because it only has a few amino acids. But it turns out it has very key amino acids for the bone and for the skin and for the cartilage. So I think collagen is a terrific thing to supplement. NICE data tells us that it improves skin health, clear differences in skin elasticity and wrinkling on skin health, and also bones, increasing bone strength, density, bone mass. It helps with joints as well. So I'm a big fan of collagen. I think it's safe. But one of the caveats is you don't want to count that in the amount of overall protein you're getting throughout the day. Soy. There's been some nice studies recently that genistein, about 54 milligrams a day, can improve bone mineral density, can lower bone turnover markers, and I'll talk about those just in a minute. There's not been studies yet that it lowers fractures. It may be just that we haven't studied it enough. It certainly has some benefits for bone. If you have 27 grams of soybean or 27 grams of tofu, which is another soy product, you would get 54 milligrams of genistein. So you don't need to take it in the supplement, though we sometimes recommend that. And it's powerful enough that it's actually a medical food. It's called Phostium Plus. And this has many different things like the MK7 and zinc and phosphate and so forth. And it has some genistein in it. Now, it turns out that This product is thousands of dollars a month, so I never order it for anyone because nobody's going to be able to pay for that, and we can get these things at a much less expensive price. But it does let you know that there's some solid data behind genistein in bone health. So Stephanie's just reported another question to me. It is about dried plums, and I'm going to answer the question about the dried plums, and I'm also going to put in almonds. So there are some manufacturer supported studies that tell us that both plums and dried plums, and which we used to know as prunes, but we call them dried plums now, and almonds have shown some increase in bone density studies, but they were small studies. They were supported by the manufacturer. They're not considered strongly credible. So I think prunes or dried plums are a reasonable food for lots of, they are high in sugar. Any dried fruit is high in sugar. But a modest amount of those can be fine for your health, and a modest amount of almonds can be great for your health. There's other things that almonds have shown in regards to overall health. So those are good foods. They're whole foods. I wouldn't bank on those in regards to making any real difference in your bone density, though. This is about vitamin K2, and this is a supplement I recommend. The data is at least moderate, and this was a review study in August of 2022, and it looked at 16 different randomized controlled trials, and it showed that there was some improved bone mineral density in the lumbar spine, but not clearly in the hip or the forearm. The lumbar spine is the part of the body that's most responsive to treatment. It's likely to get better first before things like the hip and the forearm. So that may be part of the reason that it shows this. I'm glad that it improves the lumbar spine. There's no data. The studies haven't been big enough or long enough to show that people have less fractures, though. But we know that it's safe. So this is something that I'm supportive of and something I recommend. There's other reasons I recommend vitamin K2. This was a study that supports it as well. This looked in people who have low vitamin K, and they had more fractures. People that have chronic kidney disease often have low vitamin K, and they have more fractures. So that this supports this concept that vitamin K is important for our health. And this was a study done in 2013 where 180 micrograms of vitamin K increased bone mineral density of the spine and the femoral neck. Now, in this particular study, it affected both the spine and the femoral neck. But in the study above, which is the largest study where they looked at 16 different studies and accumulated and evaluated all of the data. So the overwhelming information there is there wasn't a consistent benefit in the hip. Nonetheless, I used the bottom study to recommend the dose of 180 micrograms. The following is another slide. These are different vitamin Ks, vitamin K1, vitamin K2, MK4, and then vitamin K2, MK7. And on the right here, you'll see that the vitamin K2 has some really interesting properties. It increases something called osteocalcin, and osteocalcin is the part of the matrix that helps bones become strong and dense, and it promotes bone mineralization. So we want to do that. And the other interesting thing about vitamin K2 is it turns up something called matrix GLA protein that lowers calcium deposition in our arteries. So I think vitamin K2 makes some sense, and again, it's safe. Vitamin K1 is found in green vegetables, and it's concentrated in our liver. Vitamin K2 is found in other things like fermented foods and eggs and liver. We're going to move towards the medications now. So as I talked about before, osteoblasts are really important because they build bone, and osteoclasts, they break down bone. And actually the combination of the two keeps our bones dynamic and healthy and replenished over time. You want a good balance of those. The major classes of the medications we're going to talk about are the anti-resorptive drugs, Fosamax and Reclass, for example. There's another one called Atenol. Those are bisphosphonate medications. And then Prolia is another anti-resorptive that's of a different class, not a bisphosphonate. We'll talk more about those. And then there are the anabolic drugs, the drugs that turn up the effects of the osteoblasts to build more bone, to tip the balance in more bone building rather than less bone breakdown. I have to just move my slide here a little bit, forgive me. Got something in the way I can't read here. Okay, so medications for osteoporosis. There we go. Anti-resorptive medications. So the main anti-resorptive medications is alendronate, which is Fosamax, Residronate, which is Actonel, and Zoledronic acid, which is reclassed. The oral medications, alendronate and Residronate, are often given for 5 years, and reclass is often given once a year, IV for 3 years. We're going to talk about the side effects of these medications. I think many of you know or may know that there's something called an atypical femur fracture. And these medications were available in the mid-90s. They were used a lot, and I think maybe too much and for too long, and we had more side effects. But now the side effects are less because we understand them better, and we understand we need to limit their use. So typically we limit the oral bisphosphonates for 5 years and the IV bisphosphonate for 3 years. And then we give people a drug holiday. Now, denosumab or Prolia is not a bisphosphonate, and it doesn't have a drug holiday where you take a person off of that. We'll talk about that more too. Now, we continue the therapy for longer than 5 years for the oral or 3 years for the IV if the response isn't as good as we'd like. So, and we can take the medications, the reclass, the IV medication up to 6 years, or the oral medications up to 10 years. Denosumab, again, that's Prolia. When you want to take somebody off the Prolia, say they had a great response and their T-score was better than -1.5, then you need to switch them for a few years to the bisphosphonate, which will hold on to the bone strength over time. Denosumab within about it's given every 6 months, and after you've not had it for 6 months, very rapidly you start losing bone again. So that transition is important. Somebody that's been on denosumab or Prolia for a few years should not just discontinue it. The transition needs to be made to one of these other medications so we can really hold on to the bone benefits for a long term. The anabolic drugs, the teriparatide and Forteo, abaloparatide or Tymlos, and this new one, romosozumab, also known as Evenity, these are bone builders, and these are used when people have very low T-scores, typically in the -3 range. And they also require a transition to an anti-resorptive therapy, like the alendronate, the Fosamax, or the Actonel, or the Zoledronic acid, to hold on to their great benefits. If for some reason, sometimes insurances won't allow us to use those, and I'm very dismayed, disheartened by that, because they're so effective. They change, and they're so well tolerated, and you can have remarkable improvements in bone density with the anabolic medications. If we can't get it paid for and they can be expensive, we could use the Zoledronic acid, which is the strongest bisphosphonate, or the denosumab, which is another strong anti-absorptive medication. They're not quite as effective. And I want to say here that these anabolic drugs, particularly the Forteo and Tymlos, when they were first brought to market, there was a black box warning on them saying they could cause something called a sarcoma or a bone cancer. They came to market that is Forteo in the late 90s. And the reason was, in some studies that they did on animals only, never on human beings, there was some bone cancers called sarcoma in the bones of the rats. Well, it turns out that rats' bones never stopped growing. They have an area, a growth plate that is always there, and that's where the bone cancer occurred. In adult human beings, their growth plates close almost always by the age of 20, if not a few years later. We've never seen, in many years now, over 20 years of use of bone cancer uh, at, in adults adults using these medications. These happen. Um, the bone cancers, I don't know the exact frequency in the general population that have never had medications. Maybe I'm guessing here, but I think it's something like 3 to 5 out of a million people. And there's no increase in that in people who've used these medications. So now the black box has been removed. That's no longer a concern for these medications, even though you might see that on the internet. Now, another medication that I use frequently, and many doctors do too, for bone health is estrogen. Estrogen turns up osteoblast function and decreases osteoclast function. So, the osteoclast breaks down bone, so estrogen kind of stops that. The osteoblast tends to build bones, and estrogen supports that. In fact, in the largest study ever done in medicine called the Women's Health Initiative that was published in 2002, I believe, there was a 34% reduction in hip fractures in women taking the estrogen therapy. Estrogen is approved for prevention of osteoporosis by the FDA. That tells us a lot. And in this paper, it indicates that it's both effective and safe. Menopausal hormone therapy in the journal JAMA 2017. Among postmenopausal women, hormone therapy for a median of 5.6 years was not associated with risk of all-cause cardiovascular cancer mortality during a cumulative follow-up of the next 18 years. So we can feel very confident that there can be benefit here and it can be safely used. Bone turnover marker. So one of the things we can now measure is how fast the bone's breaking down. And we can look at a marker called CTX. And CTX is a part of the bone collagen protein. So that's why collagen is so important. When CTX is high in the bloodstream, it means the bone is breaking down and it's distributing some of the bone collagen back into the bloodstream. And we can measure that by higher levels. This is a test that should be done in the morning. CTX is, if it's less than 300, there is low bone breakdown, and we can use that to understand the medications better. And there is a bone formation marker called P1NP, and this is a different end of the collagen protein. And when it goes up, it means we're actually building more bone. I use the bone turnover markers to personalize my use of the medications, to know when I might need to give a person another dose of, say, IV zoledronic acid, which is medication I use often. We can use it less often by personalizing it, following things like the bone marker in the DEXA scan to see the response. And when we use it less, there's less side effects. Let's talk about the side effects. What are the benefits versus the risk? So one of the ways they do these studies is something called 10,000 patient year evaluation. So to give you an example of what that really means, is if you follow 1,000 patients, each for 10 years, that would be 10,000 patient years. And with that, you're going to prevent almost 300 fractures. And you will have as a side effect, if you treat someone for 5 years with a bisphosphonate, 2 atypical fractures. And if you need to treat that person for 10 years, you will have more than that, a few more than that. But in general, you will roughly prevent 100 fractures for any fracture that occurs. Now, the second issue is something called osteonecrosis of the jaw, which is something I'll show you, but it's much more rare than that. An atypical femur fracture, you can see the bones here. So I see if I can use my pointer. I don't know if you can see this or not, but this is the femoral neck here. This is the femoral neck. And that's where fractures typically occur. But in this person, they had an atypical femur fracture where it's actually part of the femoral long bone. And now we know that you can understand when this might happen because you'll see this little bump. It's called a periosteal reaction. And so if a person has hip or knee pain while they're under therapy, which again is uncommon, but if we pay attention to that and we get an x-ray, we can then prevent the person from having a fracture by treating them for this. Women that are a bit more bow-legged may have a higher risk. Asian women have a bit higher risk. But this is something that we can prevent. And never in my practice in the last 15 years have I had any of the patients I've treated have an atypical femur fracture. Because I'm a physician that specializes in osteoporosis care, I get referrals from around mid-Missouri, and I've seen 2 or 3 patients in the last 15 years that referred to me with a history of this, and we still needed to find ways to treat their bone health. So it increases the longer you take it. So we've learned that you don't give the bisphosphonates long. If you treat somebody for 2 years or less with the medications, it's 2 in 100,000. If you treat somebody near 10 years, it's 1 in 1,000 patients. So still very low. And again, for every atypical fracture, 100 fractures are prevented. If you have groin or thigh pain, when you're undergoing this, you should have an evaluation where you get an x-ray of your whole femur bone from the top to the bottom. This is a picture of osteonecrosis of the jaw. It's certainly something that's frightening appearing. It is 3 in 10,000 years of patient treatment. So it's a very rare condition. I've never seen this in my practice either. I mean, I have never had anybody referred to me with it either. The people who generally are at risk for this or have poor health, they have a history of tobacco or alcohol abuse, they have poor dentition, often a history of cancer therapy and dental surgery. Now, some of you who are on bisphosphonates or medications and need to have dental surgery, this is from the ADA and the AAOMS, that's the maxillary surgeons. And they said that the benefit of the approximate 40 to 70% reduction in fracture risk outweighs the far rarer concern of this osteonecrosis of the jaw, that a tooth extraction or invasive surgery may impart additional risk of this, especially if the person has underlying medical conditions, periodontal disease, chronic infections, smokers, excessive alcohol, diabetes, or cancer. Things like routine cleanings, fillings, scaling, root canals, and even implants do not appear to increase the risk. So this is important. And I'll just say, and we're getting towards the end here, going a little longer than I expected. Zoledronic acid is one of my go-to medications for osteoporosis management. It's given once a year, again, for about 3 years. There's something called the acute phase reaction, which is a flu-like body pain syndrome that can occur in the first few days after the medication. Fever, muscle pain, flu-like symptoms. It's not dangerous and it goes away. It can happen as much as 40% of the time, so that's a lot. But when we give it in a certain way and we have people that are hydrated and we give acetaminophen, in our clinic, we have it very uncommonly. And interestingly, and this is, I think, really important to know, if a person has an acute phase reaction, they actually have a better response to the medication in regards to lowering the risk of fracture. Though it's something we try to prevent. If a person did have that 3 days of flu-like symptoms and body pain and felt really poorly, that's solace they can take from that. It's very likely the medication is going to work particularly well in them. And the way we reduce this is make sure that people are very well hydrated before they take it. They take some acetaminophen before and after, and we give it more slowly, and that helps. And it usually happens on the first administration. So if a person gets it the second and third year, if they receive the medication again, they rarely get it the second time. So a summary slide: exercise, nutrition, and medications play a role. Strength and balance for sure. Nutrient dense, colorful plants, protein at 0.8 grams per pound. Olive oil. Olive oil really lowers inflammation. We know inflammation is a part of it. Vitamin D, you want to test your level. Calcium, get it from your food and supplements. Collagen's a great idea. Genistein can be achieved by eating soy or taking a supplement. Vitamin K2, I think, is beneficial and safe. Silica is something that helps too. I didn't get time to talk about that today. Taurine is another amino acid that can be helpful that I hadn't talked about today. And strontium is not recommended. And we are at the end, and we would have some time for questions if you all have interest in asking any. I hope this covered most of what you were wanting to know about osteoporosis. It was a long and detailed lecture. Give it a minute here. That was a thank you for sharing my story. Yeah, that was something I was not sure I would do, but I thought it was important to let you know why this meant so much to me. So someone asked about the vibration plates. The data is not very supportive for those, though the advertisements would have you think otherwise. It's not generally used in major centers for the treatment of osteoporosis. There's just not strong clinical data that suggests that works. That the vibration and the frequency is right, and the bone stress is sufficient to cause significant changes in muscle and bone. Collagen 10 to 20. The question is how much collagen is recommended. 10 to 20 grams is a great idea.
Could you stay on
The question is about Prolia. How long should you stay on it? There's a lot that goes into that. It depends on many things, but typically what we think with Prolia is if you can get the T-scores down to negative 1.5, that's a good place to be. And then you would transition to a bisphosphonate so that you would hold the bone density there, and then you could have a drug holiday after that. Prolia tends to have less side effects in regards to atypical femur fracture if you use it longer term. So it can be used longer term if needed. But for all of these medications, we want to use as much as necessary, but as little as possible. This person is interested in doing some exercise at home and website or YouTube videos to follow. Boy, I think it's not a bad idea to get a trainer and have somebody teach you how to really do squats and lunges well. Maybe learn how to do blood flow restriction therapy. Consider using a mini tramp if your knees and hips are good for that. I really like mini tramps. I do think that those have enough loading on the bones that they can make a difference. Jumping, if your body allows, jump rope or other jumping can help. There is that physical therapist researcher, Dr. Laura Diane Gregario. She has some videos online about osteoporosis exercises. So some of the exercises are to build bone and muscle, but other exercises for osteoporosis management is to keep you strong and fit and agile and with great balance. You can look into Laura Diane Gregario's work. Oh, and Steph said that you will put that in the follow-up email as well. Arm and leg bands. So the blood flow restriction therapy, the company that we use is called Be Strong, B-Strong, and you can go to their website and learn about it. It's important if you choose to do that you get educated on how to do that, and see a physical therapist, possibly even see Carol here at the clinic. Learn how to do it properly to keep yourself safe, and also so that it's effective. The bands, the last I looked, are in the $400 range. So they're not terribly expensive, but and you can use them for years. The ones I've had for years.
And then the self-pass you do.
The question was, do medications make the bones appear more dense when they're actually more brittle? There are the two major classes of medications, the medications, the anabolic that build bone, they're going to build bone that is real strong bone. There's no question about it. That's both more dense and you're going to have less fractures. The bisphosphonates, again, they're decreasing the bone breakdown so that the osteoblasts can overwhelm that and build more good, healthy bone. So the density comes from more good, healthy bone. The problem is with the bisphosphonates is that because the bones are overall less dynamic than they were when you were younger, you can get some microfractures that don't heal quite as rapidly with that. And that may be why that rare occurrence of the atypical femur fracture occurs. But once again, it's really important to take home with you that 100 fractures are prevented for any fracture that's caused. And now, since physicians are much better at using the medications for the 5 years or the 3 years, the atypical femur fractures are even less than that. That's all the questions. Thank you very much. I hope this meant it was worthwhile for you. You learned some things with it, and we're pleased to provide this information, an area that I'm very passionate about. Look forward to seeing you in the clinic, and we'll certainly send out the email and feel free to share it with your friends. And we'll be back sometime in the next several months with another topic with an integrative approach for its care. Take good care, everybody. Enjoy the rest of the fall.